Welcome to the Project Echo. This series is about intellectual disability, information and education, and it is brought to you by the West Vic Primary Health Network Spider Project, supporting people with intellectual disability to access health. This is the fourth and final session of the Series 3 of this Echo Network, and it's Tuesday the 6th of December 2022. And this session is titled The Principles of Restraint Restrictive Practice, Chemical Restraint Reduction. So I'd like to start by acknowledging the traditional owners and custodians of the lands and waterways from which we're all zooming in from today. We recognise their diversity, resilience and ongoing place that First Peoples hold on our communities. We pay our respects to the elders, both past and present, and commit to working together in the spirit of mutual understanding, respect and reconciliation. We support self-determination of First Nations peoples and organisations, and will work together on closing the gap. So my name's Robert Ward and I'm a full-time GP in Geelong, and my role is the GP facilitator for this Echo series. And I'm also the father of a 25-year-old man with intellectual disability. Today is the final session of this series of the Echo meetings. And in this series, we've discussed the interaction with mental health presentations in people living with intellectual disability. We've discussed the difficulty in diagnosis and the challenges when patients present with behaviours that are hard to understand. Some of these behaviours have serious implications for the person, their families, and those assisting them to access their community. Behaviours that can put at risk their care arrangements, their employment opportunities, or just accessing the community in which they live. Behaviour that can be at times put a person's health at risk by denying them access to health services. Behaviour that risks isolating a person and cutting them off. Throughout these sessions, we've discussed the concept of reasonable adjustments to assist patients with intellectual disability to access health services. We've looked at how communication can make it understand what people are really trying to tell us, and that some people try to communicate, or some people communicate through their behaviour. We've discussed consent in decision making, and we've also met some positive behaviour support practitioners. However, all too often patients with intellectual disability are prescribed medications to help modify their behaviour. Whether initiated by paediatricians in childhood, psychiatrists or neurologists or general practitioners. Sometimes it is prescribed at times of crisis or transition. The pressure to prescribe can be enormous in a crisis where the people's worlds seem to be falling apart and their carers and family demand something be done. We've also learned that in the care of the people with an intellectual disability is a lifelong journey. There will be periods of transition and illness, and circumstances will change. And sometimes the reason for prescribing will never really be well documented, and there was no review or exit plan. Sometimes everyone who was involved with the decision has moved on, or the patient has moved to a new care provider or doctor, and their health story has been lost. I know when I was a junior resident in the hospital in psychiatry outpatients, it was drummed into me that was to keep everything the status quo. If everything was stable, don't change anything. And I was never taught in my training how to review a diagnosis or the process involved in reducing medication. And that trait probably continues into general practice, especially if the medication was initiated by a specialist for a problem that I don't feel confident in treating. But times are changing and we're all now more thoughtful about consent and the concept of restraint. And as GPs, we're often the sole medical professional caring for adults with an intellectual disability. There are no specialist clinics to fall back on. The paediatrician has long handed over care, and the community psych team have no interest in offering an opinion. So as general practitioners, we are often it. So we do need to think about the use of medication to alter behaviour. Is it still acceptable? And what are the risks? And how we can initiate and contribute to conversations and plans to make sure that our patients have access to the best support. Maybe that's a world without necessarily using medication. So this is what our session is about today. So we're just going to introduce everyone, if we can. We're just having a look there. I'm going to, so we've got Whitney and Gemma and Katrina from the Echo team, and they'll be there running the chat in the background, and they've sort of organised everything for today. So welcome, guys, and thank you for your help over the years. Mandy Donley. Mandy's going to be our speaker today. Do you want to just introduce yourself there, Mandy?
Hi, everyone. I'm Mandy Donley. I'm the Senior Practitioner for Victoria, and I actually oversee the use of restrictive practice across disability services in Victoria. Thanks, Robert.
Thanks, Mandy. And Andrew. Good morning, Andrew. Do you want to introduce yourself as well? Only a small group of us today, isn't there?
I'm Andrew Pridding. I'm a nurse practitioner at the Victorian Dual Disability Service. So we're a specialist statewide mental health service.
Thank you, Andrew. And Jane?
Yes, I'm Jane Tracy. Lovely to see you, Mandy. I was a general practitioner, retired at the end of last year, and before that had worked for 30 years for the Centre for Developmental Disability Health at Monash Health.
Thanks, Jane. And Andrew and Jane are part of our panel today. And we've got Zach there. Good morning, Zach. Welcome again.
Thanks, Robert. Hi, everyone. I'm Zach. I'm from Gen U. I'm the Senior Behaviour Support Practitioner there.
Great, and welcome again. And Kerry is from the Spider Project from the West Vic PHN. Hi, Kerry. All right, it is a very small group today. So just really looking at the slide, we record the didactic presentation today. I don't think we've got a case presentation, so we've got a bit of time for a bit of discussion afterwards, which would be nice just to run through a few things. Just remember that things are being recorded, and so confidentiality when we're discussing patients is really important. Just going to click off that. The agenda today, we're going to have a bit of a CPD update from Katrina Martin from the West Vic PHN. I don't know if Katrina's on board at the moment, but she's going to just update that. Then we're going to have a didactic presentation from Mandy Donley, who's the senior practitioner for Victoria Senior Practitioner. She's overseeing restrictive practices with the NDIS providers. And so we can have a discussion about that later. So I'd just like to remind you of case studies. So we don't have a case study today, but certainly next year, hopefully we can fire up the case studies again, because they're an important way for us to follow up what we're talking about during the session. We will have a quick reminder about professional development later on, but there's certainly you can find out some more information from the website there about professional development and points for the next triennium. There's a survey to click onto to help the Spider team improve these sessions. So if we look at the learning outcomes for the series, for the whole series, we've got to recall the terminology used when describing intellectual disability and identify solutions to help support primary healthcare professionals deliver high quality care in the primary health setting for people with an intellectual disability, and to assess the disparities in healthcare inequities in accessing primary healthcare for people with an intellectual disability, and to understand the United Nations Conventions of the Rights of a Person with Disability and our legal obligations. So learning outcomes for this session is to identify the main purposes of the Disability Act, describe the chemical restraint reduction strategy, and to describe the challenges and experienced during restraint restrictive practice by people with an intellectual disability and their carers, GPs, specialists and paediatricians, and all the sort of allied health and primary healthcare practitioners there. So now we were having, Katrina was going to update us, but it doesn't look like she's here. Is that right?
We might go straight to the
Katrina
didactic.
is there. Sorry, Katrina. Sorry, Katrina. I had someone else totally in my head. Did you want to go through that, or is there just not enough really GPs in the?
Yeah,
in the
I was
room?
just chatting to Whitney offline, and I said if we've only got a couple of GPs here, so I might just save mine until later in case some more GPs join. And if not, I'll just do a super quick CPD update at the very end, just for the changes that are coming up from 1st of January. So go ahead, and I'll just wait till a bit later on.
All right. Thanks for that. All right, so we might move on to our presentation with Mandy. I know there's not a lot of people in the room at the moment, Mandy, but we do record this, and so people have access afterwards and often find a better time to access the information. So it's going to be a really important session today. So Mandy is the Victorian Senior Practitioner, and Mandy's office has responsibility under the Disability Act for ensuring the rights of people who are subject ensuring that the rights of people who are subject to regulated restrictive practices and compulsory treatment are protected and appropriate standards are complied with. So I'm going to hand over to you, Mandy, for your presentation. So welcome this morning.
Thanks, Robert. And is that sharing okay? Can you see the PowerPoint?
Yes, we can,
Yes.
Mandy.
Yeah.
Yes, we can.
Terrific. Thanks very much. And thanks for that introduction, Robert. I too would like to acknowledge the traditional custodians of the lands on which we're meeting today. For me, it's the Wurundjeri people of the Kulin Nation, and I'd like to acknowledge their elders, past and present, and anyone who may be in the meeting here today. Now, I'll just test this on Zoom, and is that moving?
That is moving. Well done.
Awesome, thank you. So I'm a mental health nurse. I trained in a 1,000-bed institution many years ago in the northeast of England, and I emigrated to Australia in '96, and my first 10 years was spent in forensic psychiatry, working at Mon Park and then Thomas Embling Hospital. But in 2007, Jeffrey Chan, who was the inaugural senior practitioner for disability services in Australia and here in Victoria, asked me to come across to his office for a 6-month period and look at the issue of chemical restraint. And so, of course, 13 years later, I was still trying to get my head around the use of medications in response to behaviours of concern. But at that time, the senior practitioner's office was very much a one-stop shop for restrictive practice. Since then, I've regulated restrictive practice across the 1,600 Victorian schools, moved to ACT and become the inaugural senior practitioner in Canberra. But the good thing about the Senior Practitioner Act in ACT is it regulates restrictive practice across child protection, schools and disability services, which is something I continue to aim for in Victoria, because that actually achieves true early intervention. And the Act actually demands best practice and that all the sectors work together for the benefit of the child. I've come back to Victoria, and the Disability Act has changed considerably, but people still have the old Act in their heads, and that we're very much the one-stop shop still. So today, I'm just going to describe what functions remain within the Disability Act regarding the reduction and elimination of restrictive practice. And I'm specifically going to concentrate on the use of medications for behaviours of concern. So, as Robert's already said, the Act is very much embedded in the UN Convention and the Charter of Human Rights. Of course, Victoria is a signatory to the Charter. So every piece of legislation, every policy is compatible with that Charter. But how we actually enliven the UN Convention within our practice is very much our own responsibility. So that's something that I do strive to do on a daily basis. So what's changed within the Act is it not only covers all the residual state-funded services, which are primarily forensic services currently, it also covers all the NDIS services across the state. And in 2019, the Act changed and adopted all of the definitions within the NDIS rules and legislation and embedded them in our Act. Fortunately, most of the definitions are based on the Victorian definitions, so there wasn't too much of a change for us there. So we're still very much embedded in the NDIS rules and legislation, but we also have a residual number of services. Also, there's a number of people who don't qualify for the NDIS. We have a number of people who don't have citizenship, who may have a disability and require service provision as well. So it's my job to ensure that all service provision is looking at best practice and least restrictive options. So the actual functions of the senior practitioner that remain in the Act, and this is the only Act that keeps these functions, is I need to write guidelines and standards. I also need to make sure that the rights of people with a disability are enlivened and recognised in all service provision. I can actually give directions to providers. And the senior practitioner, Frank Lambrick, who was in the job till late last year, his last direction was around people with psychosocial disability, and that people with psychosocial disability should not be subject to any restrictive practices. But I'll talk a little bit about that later. I'm also expected to generate research and have relationships with tertiary bodies across the country to generate research in this area. And I also have the responsibility to report back to the Minister and provide recommendations to the Minister around practice. So I'm delighted to say that these functions have stayed intact throughout all of the changes. And this is what gives strength to the senior practitioner position here in Victoria. I'm also going to pinch a function from the ACT legislation, which I'm going to have put into the amended Act early next year. And that is that the senior practitioner will promote the human rights of people with a disability to the greatest extent possible. So I'm going to borrow that function and put it into the Victorian Act. Obviously, we don't just expect that people are guided by just the Act or just the NDIS legislation. Regarding practice, we expect that people look at practice more broadly. So we want to see Huckshorne 6 core strategies embedded in the practice of all disability support providers across Victoria. And as I explained to everybody, this is a model you can't cherry pick from. You do it all, or it's not going to work in the reduction and elimination of restrictive practice. And I often see people with fantastic leadership within their organisation, but data doesn't underpin what they do. A huge gap is the actual supervision and the use of reflective practice and the use of actuarial tools to do risk assessments, etc. So we promote that people look at each and every one of these areas, and we ask them to look at a nice checklist that's been generated in the UK from the PBS Academy, so the Positive Behaviour Support Academy, which is a bit of a checklist for organisations around where are we at with this? What activity have we actually got going on around this model? But it only covers the first 5 aspects. It doesn't cover supervision and reflective practice. So I ask people to add that in and look at supervision across their own organisation. So this is the model of practice that we very much promote, and we expect to see activity in each of these areas. And if we have got activity in each of these areas, we will then start to see a reduction of restrictive practice. Now, as I said, chemical restraint, mechanical restraint, and seclusion were defined in the 2007 Act. Physical restraint, for some reason, the lawyers that wrote the Act didn't think physical restraint occurred in disability provision across Victoria. I'm not quite sure what world they were living in, But anyway, as I said, the senior practitioner could put out directions. So the physical restraint reduction paper was written and it was launched in 2011. And I'm about to do a 10-year review of that because we've had that nice little turnaround in 2019, where up until then, we had maybe 1 or 2 emergency response plans with planned physical restraint in. Otherwise, physical restraint remained as an emergency response in a duty of care situation. So where somebody was going to get hurt and you'd expect anybody to step in. So that's how we'd operated till 2019. Because now physical restraint comes under the NDIS rules. I have 41 behaviour support plans that contain physical restraint as an authorised response. Obviously, that's extremely alarming to me as the senior practitioner. So I'm going to do a review of how physical restraint has actually been authorised across Victoria in the last 10 years. And since 2007, we always had an other in the Act where people would report locked doors, fences, locked windows. This has then been built upon and NOUS did a review of what people were doing across the country. And this has become reportable environmental restraint. And that's only been reported in Victoria since 2020. So I have to say environmental restraint is absolutely looking at the heels of chemical restraint for the most used restrictive practice in Victoria. So that's how the Act has developed in the oversight of restrictive practices in Victoria. And as I say, we now use the NDIS definition of chemical restraint, which is the use of medication or chemical substance for the primary purpose of influencing a person's behaviour. It does not include the use of medications prescribed by a medical practitioner for the treatment of or to enable treatment of a diagnosed mental disorder, a physical illness, or a physical condition. Now, I'm sure everybody in the meeting today is very aware of the arguments that have gone on regarding this definition over the years, but I would equally say everybody in this room is very, very clear when medication is used in response to behaviours of concern, and that research would tell you if positive behaviour support was implemented with fidelity, you could reduce and eliminate that medication. That's what we're talking about. What I always say to people is go with the research. For this person, is positive behaviour support going to work? If it is, use it. And then we can reduce those medications. Now, this is a prescription sheet from 2009, and a couple of people in the room may recognise this prescription sheet. This was actually after the start of the reduction of these medications. The young man was actually originally on 16 milligrams of risperidone. That was then reduced to 8. And if you see, for the Zyprexa, he was actually on 50 milligrams a night. Now, this is a young man who had never, ever acquired a diagnosis of mental illness. And in fact, if he had a diagnosis of mental illness, I wouldn't expect to see this kind of polypharmacy anyway. However, just walked into a day service, opened the file, and this was the number 1 prescription sheet I was looking at. I met the young man. He had an extremely distended abdomen. He was sitting very lethargic in the corner and extremely unhappy. Now, the reason we make such a fuss about the use of psychotropic medication in response to behaviours of concern is about the side effects. People with mental illness hate taking these medications because they have horrible side effects. But the reason they take them is because it gives them some respite from their persistent hallucinations or delusions. So they'd rather take them and engage in the activities of daily living that they can than not take them and be plagued 24/7. To give these drugs to people that don't actually need them, to me, is highly unethical. However, we are in a society that expects these drugs to be given. We're in a very highly dependent society that expects to have a tablet for everything, and that a tablet will cure everything. So the reduction of chemical restraint is a societal issue, and it's everybody's business. Families are just trying to do the best they can. Disability providers are trying to do the best they can. Prescribers are trying to do the best they can. But in a world where we've got underfunded services who have multiple people with behaviours of concern under the same roof line, we're setting everybody up for failure. Everybody. So this is very much the lens through which I look at the reduction and elimination of any of the restrictive practices. It's a societal issue, and it's a systemic issue, and it's a whole of government issue. So now that I've come back to Victorian government, I'm a bit like the ghost of Christmas past. I'm reminding absolutely everybody of all the commitments that have been made over the years since 2007. And I'm checking up on where every piece of funding that we have put into the system, where's it gone? What has it achieved? What difference have we seen? So, as I said, I'm like the ghost of Christmas past for Victorian government, because I remember every piece of funding, every policy, every guideline, every Burke bid, every piece of budget discussion that's gone on around this. So we're revisiting, which is a little bit depressing. We're revisiting things that we thought we'd nailed in 2012, 2013, but that's okay. That's my job. So that's what I'll do, and I'll do it until we get back to where we were pre-2019 when we entered into the NDIS system, because as we know, any national system is the lowest common denominator. And Victoria has always led in this area, and we've been dragged down a little bit. We need to get back to where we were and then move forward. So for your interest, these are the stats over the years for the mechanical, physical, and seclusion restrictive practice data. As you can see, the numbers, these are actual people, not episodes. These are people. When you look at the actual episodes, it goes into thousands over the years. But these three restrictive practices have always been in the fairly low numbers over the years. However, as I said, chemical restraint is the most used restrictive practice in Victoria. So in 2018-19, we had 2,382 people reported to my office. Everybody has always recognised that as significant underreporting. And if you look at a study that was done across New Zealand in the early 2000s, who have a similar population to us, and they actually compared their Medicare data, the prescribing of psychotropic medication, and whether somebody actually was a registered disability client or not. They came up with a number of 32,000 people with a disability prescribed psychotropic medication. Now, obviously, a number of those people actually had mental illness. But even if you took out those people who had mental illness, you still had thousands of people prescribed psychotropic medication. We are yet to replicate that study, but I do keep reminding the Commission it was a nice study to do, and it would be very useful to do here in Australia. So if we look at the percentage of people restrained via chemical restraint in Victoria across all the people subject to restrictive practice, we actually have 84%. And this is why I've engaged in over 15 funded projects regarding the reduction of chemical restraint. Now, our restrictive practice data system used to gather every single episode of administration. In 2019, that data was taken from us, and the senior practitioners' only role around the reduction and elimination of restrictive practice is to authorise it. So we don't get any of our data. We were always promised by the Commission that once a year they would give us our data back, so it would inform our authorisation of behaviour support plans containing restrictive practice. We are yet to receive that data. And in fact, the Commissioner told me not so long ago, I'm not getting it. So without that data, we're pretty much in trouble. So I continue to insist, and I will go to the Federal Minister if needed, because data-informed practice is our only way forward. So hopefully I get my data eventually, but I thought you would be particularly interested in these top 10 medications that have been prescribed over the years for people with a disability. And you can have these slides and look at them at your leisure. And then we see a slight difference in prescribing of these medications depending on whether the primary diagnosis is intellectual disability. And you can still see risperidone is very much the drug of choice, or whether the prescribing is for primary diagnosis of autism. We still see risperidone up front. And people ask about melatonin. We only ever put melatonin into a behaviour support plan if it's amongst other chemical restraint. We wouldn't dream of doing a behaviour support plan just for the use of melatonin, but it's obviously not the least restrictive way of getting someone off to sleep. You know, so we encourage people to look at sleep hygiene and more appropriate ways of helping the person to get to sleep. And as you can see, there's a steep rise from 2010 in the use of risperidone and all the other drugs for autism, because up until that point, people were very clear to us that all the drugs people were on were actually treating autism. But as we know, these drugs may alleviate some of the symptoms, but they're certainly not treating the autism. And if the person can not have to take risperidone with its 26 documented side effects, that would be terrific. So as I say, please feel free to circulate these slides to anybody who may be interested in them. And I'm also happy to share this data with anyone that might be doing a master's degree or a PhD. Happy to share our data. Obviously, the age group, we see a lot less children, but I've always had around 500 children on the RID system. But since the NDIS rules came into effect, that has halved, because all of the children who are now in out-of-home care under child protection don't need to get anything authorised by our office because they're not registered disability services. So I've lost half my kids. And again, just looking at the drugs, and the difference between children and adults. Again, risperidone is still the highest flyer. And this is just a demonstration of how we've seen reduction in the typicals over the years and the move to the atypicals, which is a good thing, I suppose, but we're still getting people chemically restrained, but we're moving to less toxic drugs. And the use of Melorol, when I first came into the services in 2007, surprised me, given the chief psychiatrist had banned its use in 2002. But we had a number of pharmacists who'd stockpiled it for use in people with a disability. Now, to me, that just screams a huge attitudinal problem around, no, we can't prescribe it for people with mental illness, but we can continue to prescribe it for people with a disability. Took us about a year to stop that happening. Now, we've done 11 years of research, and this is the link to that. Frank Lambert and Lynn Webber actually got a prize for this article, so it's well worth reading. And these are just some of the reports, and Jane will recognise these, that our data has been used for to generate over the years. I would encourage anybody to have a read of these. They're still very valid today in their recommendations, particularly this one looking at the implications for policy and practice. And this actually outlines recommendations for disability support staff education, GP education, and psychiatrist education. So this one in particular, I would say, is an excellent report to continue to refer back to. It managed to get me $8.4 million to develop 2 MIDI clinics in Victoria, the MIDI Y and the MIDI A, based on these reports that we've done over the years. So if anybody would like copies of these, happy to provide them. Otherwise, they're sitting on our website. The use of antilibidinal medication, obviously, we'd expect that to be primarily for people who've offended. However, I was constantly seeing the use of antilibidinal medication for young men who certainly weren't offending. They were just engaging in perfectly normal sexual behaviour, but perhaps hadn't been taught personal and private space, so were masturbating in the middle of Coles Aisle, probably not the best place to do it, and with a little bit of education and realising where the private space was, we could get rid of these medications. But I also saw a huge number of SSRIs being used for this population for the antilibidinal side effects. Sometimes at the request of parents, usually at the request of the disability support provider. So these reports look at some really interesting patterns that we've seen over the years in prescribing, but this pretty much sums up the pathway of these different research projects, because when the senior practitioner came into being in 2007 and took over from the IDRP, who used to regulate chemical restraint, they were handed 88 case files for people from Q residential services that they were not quite sure whether the medications were therapeutic or chemical restraint. And that's why we had CDDH look at those original 88 people. And the outcome of that was, I think, 68% were seen to be on chemical restraint. And a small number were actually on medication for mental illness. But even that could be rationalised because it was gross polypharmacy. So that's how all of those projects are linked, because we had a significant number of people from Q residential services who were 55 plus. So we had that nice report looking at the older age group as well. And then all of these projects came out of that original 2010 Disability and Mental Health, the implications for policy and practice. So we had a nice collection of reports done then. And as I said, with every report, that led to me asking for funding to generate better levels of service for people with a disability. So none of these ever got left on a shelf. They were just a piece in the puzzle to getting extra funding to capacity build the sector. We also looked at education for GPs. Jane was heavily involved in the development of the 4 modules for GPs. We also had 3 modules developed for the College of Psychiatrists. I also worked with the College for Psychiatric Nurses to look at how we could embed dual disability and disability into core training. So again, all of these may have stalled, shall we say, and we just need to breathe new life into them. The content is still excellent, so we just need to review, breathe new life, and move forward. I've been very, very lucky over the years to come across some experts in this field, and Shumi Deb is someone who I've thoroughly enjoyed engaging with from Imperial College London. Shumi, Jenny, Luis Salvador Curla were co-authors of the WPA guidelines on the prescribing of psychotropic medication for people with an intellectual disability. And Shumi has gone on, and I'm sure people would have heard STOMP referred to, Stop the Overuse of Medication for People with an Intellectual Disability and or Autism, quoted in the Disability Royal Commission many, many, many times. Shumi has given me permission to develop STOMP Oz. Now, obviously, STOMP Oz is bigger than just Victoria, so ACID have kindly posted it on their webpage. And as we know, ACID only want any research-based work that they can promote. So I've encouraged people across the country to use this as a central repository for any of their work that they're doing now or may do in the future, and have that sitting on this webpage. So it's a one-stop shop for everybody. And we're also using the Spectrum resources that Shumi has developed as part of the STOMP program in a project that we're doing with Spider, where the Victorian senior practitioner will do the education of families, people with a disability and disability support workers on this side of the surgery door. And then that side of the surgery door will very much sit with Spider, yourselves, and we have a pharmacist engaged in the project as well. So we're hoping that this will actually create a seamless pathway to deprescribing. So that's the intent. So the person in receipt of the service hopefully will be totally unaware of the immense amount of work that's going on around them and behind the scenes around educating everybody, make sure everybody knows what the drugs are, make sure everybody knows what alternatives to the drugs are, and then slowly, in collaboration with the behaviour support practitioners, reducing these medications as far down as we can, hopefully eliminate, but we need to take this really, really slow. So I'm very excited. This project, the ethics application is finished and it's just about to be submitted. So once we've got the ethics application, it'll be all systems go. And then, as I said, we have the STOMP Oz network, and what I really want people to do is make pledges and actually have these pledges on their own websites. Talk to your own CEOs, because the more we can put this out there, the more we can use hashtag StompOz, the more attention we draw to this issue and we get people talking about it. Now, I know in the 3 years I worked across the 1,600 government schools in Victoria, having teachers talk about this was just so valuable. And now schools report all of their restrictive practices, and there's an enormous data set sitting within the Department of Education currently, which I'm hoping will be published at some point. But the number of children we'd had turned away from school and told don't come back until you've got risperidone, or for young girls starting their period, don't come back until you've got menstrual suppression. It's just unacceptable. It's totally unacceptable. So we just need to start the conversation, and it's things like having this pledge on your website that start this conversation, because people will go, what's that about? And there's our website, and that's it. Thank you for listening. Jane and everyone else knows I can talk forever about this, because I won't stop until we get somewhere. So thank you.
Thank you, Mandy. Obviously very passionate about a very important topic, and thanks for all your work there. So I was wondering, we don't have a big group, so it'd be good just to have a chat amongst ourselves if anyone had any sort of questions or wanted to add anything to what Mandy had to say.
Just got a question in relation to our experience with that at our service. We're seeing a lot of people, adults, being referred with requests for ADHD assessments and requesting prescription of psychostimulants. I'm wondering if you're seeing any of that in your work.
Well, I'm actually hearing about that personally. However, because ADHD and the medications associated with it are not considered chemical restraint, we don't see much of it coming across the our desks. However, Andrew, I'm quite surprised at how many people in the general population are actually considering ADHD as a diagnosis for themselves. And I know one particular person got prescribed Ritalin and had a significant amount of weight loss. So I'm wondering if there are other drivers for this. And I think this would make a fascinating research project. But again, just contributes to that societal expectation that there's a pill for everything and people's need to pathologize everything.
It seems a lot of people are getting the information online and are presenting to the psychiatrist with a list of symptoms that they've ticked off.
Yes.
There's certainly an explosion in general practice about people requesting it and requesting referrals.
Yeah. And I'm seeing the same with cannabis oil.
Yes. Yeah.
Mm-hmm.
So I'm saying a lot of my participants who've been on psychotropic medication, now the medication's going, but it's being replaced with cannabis oil. And
particularly autism is cannabis oil. We're getting lots of requests for autism.
And I'm torn because I don't know whether that's a good thing or a bad thing. Deep down, I think, why aren't people using positive behaviour support? I know it's hard yakka, but it's a far healthier option. But cannabis oil appears to be a healthier option than risperidone.
They probably said that about risperidone 20 years ago.
I was going to say, and I was involved in the trials for risperidone, and I think we were given doses up to 36 milligrams a day. So yeah, in 10 years' time, we'll see what damage cannabis oil has done to everybody. But yeah, I'm having a daily argument about cannabis oil, I have to say. But prescribers are saying it's a better option, Mandy, just go with it. But same hesitation you have, Andrew. why anything at all? Why not just keep striving to have nothing?
Thank you.
Tracy, you've got your hand up there.
Hi, Robert. I just wanted to emphasise, thank you, Mandy. That was a fantastic presentation. So interesting, all that data. GPs have in the past reached for their prescription pad because there's been so few other options, and faced with families or support staff in great distress and people with disability in situations in which they were either at risk of injury themselves or harming other people or being restricted in their activities, it seemed like the best option was to prescribe. Now it's very different. One of the great benefits of the NDIS has been the explosion in availability of positive behaviour support. Now, I know every man and his dog is now PBS practitioner, and that's not always good, but there is an availability now of people to access positive behaviour support that was not available before. And so I guess it's a really important time for GPs to be really aware to reach out to people's support coordinator at the NDIS and start that process, if it hasn't been started already, to get behaviour support in people's plans so that chemical restraint is not the only way to address the issues that GPs are facing.
Absolutely, Jane. And I've always seen everybody just as on the team for the person. And I keep seeing steps being missed out. And I keep seeing people not going to the GP and saying, is there any physical cause that could be driving? And I know GPs are doing this silently and just eliminating all the cause. I'm wondering if we need to overtly say, I will just make sure there's nothing physical causing this behaviour first, so that people hear that. So because
I think really a good plan. That case that you gave the prescription, the medication chart for, you said he had a distended abdomen. The first thing that occurred to me was, is he constipated?
Absolutely.
Those simple little things like that people are being treated and treated and treated and treated for, and nobody's thinking, oh, he's really blocked up, he's in pain.
Yeah, and that's what I'm hoping the Spectrum Spider project's going to do. We will map out for everybody what this actually looks like. So firstly, you eliminate any physical causes and make sure they're treated. But then what I also see as a gap is when people do go on to behaviour support plans, the groundwork's not done, the assessments aren't done first. So you've got support coordinators who don't realise that if the person doesn't use speech to communicate, you do the communication assessment before you even venture anywhere near a behaviour support plan. And yes, you might put those immediate steps in place, which is the whole idea of an interim behaviour support plan. You put something in place for the first 6 months while all this other work's done. Support coordinators don't know that, and they're not doing it. And organisations don't know that, and they're not doing it. So we really do need to map this entire process out for people so that they know what they're doing, and that all of the money that NDIS is pouring into behaviour support is meaningful. Because everyone in this room knows assessment, planning, implementation, evaluation. That's not the way things are done under NDIS. You grab, and Zach will know this, he'll be available, so he'll do his behaviour support plan, and Zach will be going, where's all the assessments? And they haven't been done, they haven't even been referred to. So it's a really interesting space to be in. And I'll never forget, because I also oversee compulsory treatment. I was sitting in a VCAT hearing with a barrister once, and they actually said, but Ms. Donley, you asked for the assessments to be done. At no point did you say that the plan should be based on those assessments. So That was from a barrister, and that was a great learning moment for me, because I thought, he doesn't get it. The psychologist who'd employed him got it and should have known better. Brush shelved that. And I just thought, right, I need to keep spelling this out. So that's what I fully intend to do in this Spectrum Spider project. And you saw the roadway. I plan on spelling each of these stages out so that we give NDIS a roadmap to do this, so that support coordinators and everybody knows what they're aiming for and what they're doing.
Can I ask, Mandy, just sort of coming up to the end of our time now, I just want to know, for people who are not with an organisation hooked up with the NDIS, they're just living with their parents or with in a boarding house or with something, who are not as connected with all the rules, they can be quite vulnerable, can't they? Because they're connected to their GP and the boarding house, or the parent comes like, I want some risperidone, that's what, and the GP, and there's no one overseeing that, is there?
Absolutely not, Robert. Yeah. And that's always been my issue, that we really need to be working with the support coordinators for NDIS and skilling them up. Now, I've had that conversation since before they decided support coordinators were going to be called support coordinators, because obviously all of these discussions went on within government. And we pointed out many years ago, they're the people that need to be the most skilled practitioners, because they're the key to everything. They're the coordinators of this person's care. And if they don't know what they're doing and they're working on guesswork, what chance does the person have? So hopefully this roadmap will absolutely help support coordinators and GPs, where they're the only two professionals involved in somebody's life, to actually work their way through the system to a meaningful outcome. Hopefully. That's the intent.
Look, we are getting up to our 8:30 time slot, so I'd just like to thank you, Mandy, for your contribution today. There was a fantastic talk, and hope it's there recorded for people to look at a later date when maybe it's not as early in the morning for them. I'd like to thank Jane and Andrew for their contribution today. Katrina, did you want to talk about the CPD, or we'll do that another time? Yeah,
we'll do it another time. I'll just maybe share a slide or two in the slide deck. How's that sound?
Okay, look, that
don't want to hold people up.
No.
Yeah, okay,
look,
thanks.
And just to finalise today, we really just remind people about the health pathways for intellectual disability that's available where all good health pathways are. And we'll go on to, and reminded that the Echo series has been brought to you by the Spider team. So I'd really like to thank Kerry and Nicole for all their hard work throughout the year, because it's been a fantastic journey with them, and they've put in a lot of work, and it's been brilliant. So it's sort of a culmination of this year. So thank you for that. There's an evaluation slide, I think, or case study submission for next year. We've sort of missed out on a few case studies this year, so it'd be nice to get some next year to have a discussion with our topics. And talking about next year, this was our final session for this year, and so we're going to be back after the Christmas break, and you'll find out a little bit about that. So we may change the time a little bit to help more people get access to these sessions. Oh, and don't forget the evaluation. If you want to click on that, that would be fantastic. So I'd just like to wish everyone a very happy Christmas, and thank everyone for their contribution, particularly the Spider people. Andrew's been here a couple of sessions. It's been great. Jane, you've been fantastic and always a great contributor. So it's been lovely to see you every fortnight and listen to your wise words of wisdom. Zach's been here a few times as well. So thanks, Zach. Good to have your contribution to the team. And thanks again, Mandy. So have a very Merry Christmas, everyone. And we will see you sometime next year. Thank you.